Welcome to Advanced Patient Care, the exclusive podcast series by Vance Thompson Vision. Our purpose is to keep you at the forefront of patient care through dynamic insights, practical clinic tips, and engaging expert discussions. Join us on a journey of continuous learning and professional growth as we delve into the latest advancements in ophthalmology and optometry. Our mission is clear: empower eye care providers with the knowledge and tools needed to deliver exceptional patient care. The Advanced Patient Care podcast is dedicated to elevating our craft, one episode at a time.
Well, thanks everyone for joining us today. Today we'll be talking about our options in refractive surgery. My name is Daniel Terveen. I'm a cataract, refractive, cornea, and glaucoma surgeon at Vance Thompson Vision in Sioux Falls, South Dakota. And I'm joined today by two esteemed panelists who are really experts in the field. Doug, go ahead and introduce yourself and tell everyone how long you've been doing this.
You bet.
You can use decades, so the numbers are small.
Yeah, I'm measured in decades now. Hi, my name is Doug Wallen. I'm an optometrist at Vance Thompson Vision here in Sioux Falls, and started working with Vance in the refractive surgery world back in 1995. So actually, it was Valentine's Day of '95. So not coming up pretty soon. Valentine's Day of 2025, it'll be 30 years. So had a fun ride with this, and one of our focuses has been refractive surgery over the years. Personally, I've had LASIK myself back in 1996 and was high myope, about six and a half diopter myope at that time, and had LASIK then. So excited to be here today to talk about all that we do today for refractive surgery. Fun to be with you guys.
Hey guys, Brent Kramer here. I am also a surgeon at Vance Thompson Vision. I do surgery in Sioux Falls and Alexandria, Minnesota. Happy to talk about LASIK. I was 4 years old when Doug joined Vance. I was not doing LASIK at that time. I haven't had LASIK because I don't have a prescription, but my wife had LASIK and she loves it.
Yeah, awesome. Well, Doug, tell us a bit of how the landscape has changed, what procedures we have available to patients now, and maybe just go through a little bit of the history and what we have for options available to patients right now.
Yeah, you bet. So, originally, prior to the laser coming out in the late 80s and early 90s, it was incisional surgery like RK. And then when the laser came out in the early to mid 90s and FDA approved in October of 1996, what we started to see is kind of an explosion in the world of corneal refractive surgery. And we had procedures like PRK, surface laser come out. We had LASIK come out. And those really dominated everything for many, many decades because LASIK and PRKs did such a great job of correcting low, moderate, and myopes and astigmatism and hyperopia and really dominated it. Now, then we started to have things like intraocular lenses come along and phakic IOLs that could correct higher amounts of correction. And of course, all during that time, intraocular lens surgery, specifically cataract surgery and removal of the crystalline lens and replacing it with an IOL, started to also dominate it. So the biggest change I've seen over my period of time is refractive surgery becoming more lens-based as compared to corneal-based. And so I think we're still going to see that continue. LASIK and PRK are still wonderful procedures used in the right situations, which we're going to cover a lot of that today and in this podcast. But what I'm seeing is the lens-based surgeries are really starting to grab a foothold and take over because of the technology and because of the ability they have to correct people for a long, long period of time. So that's probably the biggest thing that I've changed. So we'll probably spend most of our time talking about LASIK, PRK. We'll talk about phakic IOLs. We'll talk about lens exchanges and cataract surgery and the implants we use there. And that's kind of really where we're at. And I consider all of these surgeries refractive surgeries, and we just separate them out into whether you're talking about a corneal refractive surgery or whether you're talking about a lens-based refractive surgery. And I think that's where you kind of just sit right now in the technology world. So
Yeah, if we think about a refractive surgery as treating refractive error, I think that's, those are all four definitely types of refractive treatments. Brent, with all those options, maybe talk through a little bit how you choose the ideal candidate, maybe someone in their 20s, 30s, 40s, 50s. And then I'd love to hear what your guys' is maybe percent breakdown of refractive patients. 30% mostly are 30% are LASIK, 30% are, RLE, 5% is PRK. And maybe just talk through that so we can give the audience a little bit of a sense of how much of each we're doing, especially in the different decades.
Love it, love it. So, when I think about this in my mind, there's an x-axis and a y-axis, and along my y-axis is kind of the amount of treatment, like how much myopia or hyperopia, maybe, astigmatism factors in that a little bit as well. And then along the x-axis is age. And so certainly, bread and butter, common things being common, are low to moderate myopes are the ones coming in for refractive surgery, typically in their 20s and 30s. And for that, I would say by and large, a low to moderate myope, I'm still LASIK all day. Nothing's really dethroned LASIK, in my opinion. Boy, folks are happy. And so it's usually slam dunk LASIK, assuming the cornea looks good, and we can kind of talk about some of our advanced technology we use to think about that. So then we get into the decades of 40s, 50s, and 40s, I would say, is the maybe a little bit tougher one. And I'm having a conversation. I'm looking at how big that treatment is. And then I'm also talking a little bit about, have you started doing this, taking your glasses off a little bit to see up close? Because once presbyopia starts to set in, people typically, I would say 9 out of 10 people that come to me in their 40s, if they have presbyopia, they also want it treated. It's pretty rare somebody comes in, but I've had it where a myope comes in and says, Doc, I wear my contacts and put cheaters on, and I love it. I just want to get rid of my contacts because I don't tolerate them. That's great. Shoot for distance. They know and expect to wear cheaters, and that's fine. But typically they're coming in thinking, boy, I want to fix my astigmatism. I want to fix my nearsightedness, and I don't want to have to wear cheaters. And so those patients, with the advancing IOL technology, I'm really starting to talk more and more about a refractive lens exchange, in mid to upper 40s, and especially when we get into the 50s, because that crystalline lens isn't helping anymore. That presbyopia has set into a point where people are noticing it. And so leaning towards refractive lens exchange in those situations, I'm doing less and less blended or monovision LASIK. Certainly I do it. The slam dunk blended or monovision LASIKs are the -1.5 to -2.5 patients that come in wearing a contact lens in one eye, because then they're going to tolerate it. But if I'm doing -6 and we're going to have to treat both eyes and they're nearing 50, I'm really looking at a lens-based solution because it's a permanent solution.
Mm-hmm.
The other conversation I have with this is, what's going to happen is, even if you're okay wearing cheaters, one thing that is going to happen over the next 10 to 15 years before you have a full-blown cataract is your refractive error in your glasses prescription is going to change a little bit, because that lens is going to change. So even if I do LASIK on you, give you perfect distance vision, and you're okay wearing cheaters, you might drift back into glasses over the next 5 years. And so the conversation gets a little bit longer. And then, certainly 50 and above, it's pretty rare I look at a cornea-based solution like LASIK, and I'm looking at a lens-based solution because it's the permanent fix.
Mm-hmm.
Hyperopes, similar story, except I look to the lens-based solutions even younger. Certainly in the 40s, maybe even into the 30s, we look at fixing it from a lens-based standpoint, because boy, some things I've learned as a cornea specialist over the years, the cornea really doesn't mind being flattened. It doesn't love being steepened. And certainly we can do low hyperopes, but those moderate to high hyperopes really love that. And then we get into the more extremes, like a high myope, like that -8, -10 or higher. Then I'm looking at an ICL if they're younger, and a lens-based solution if they're older. Boy, the Evo ICL is just it's great technology, and it's made putting in an ICL so easy for us. And so lens, but they get to keep their phakic lens because it's still helping them. So anyways,
Yeah.
just kind of a few of things of where I'm at. Dan, in regards to, how much am I doing this? I think the biggest thing I'll comment on, and I'll let Doug take it from here, is I'm doing not that much PRK. I'm doing a lot of LASIK, and then I'm doing a fair chunk of refractive lens exchanges, and then a little bit of ICL when the situation's right. Doug, what do you think?
Yeah, I agree. From a number standpoint, I don't know what the percentage are. A majority of the corneal-based surgeries are LASIK. We still do occasional PRKs, but it's mostly LASIK. I think because the phakic IOLs, like the ICL, does so well. It used to be that you would only restrict the ICL to real high myopes, and you try to push LASIK up in the 7 or 8 or 9 diopter range if you could, and they had nice thick corneas. But we've also found that changing the cornea by that many diopters, the cornea can be flattened a lot more than it can be steepened. I agree with you there, but you can also reach a point where you flatten it so much that it kind of loses some of its optical properties, and people feel like they just don't have a good image quality. And so I think ICL being able to go to much lower numbers. I mean, the ICL goes down to -3, but not many people think about -3 and -4 diopter myopes putting an ICL in. And now with the advanced tech, and so it's mostly LASIK. Again, for the cornea, we do a lot of the ICLs and phakic IOLs, some PRK, and probably the biggest growth I see in our practice is the refractive lens exchange, because I now see a fairly large percentage of our patient population that are coming in. It used to be the people coming in for the refractive consults to correct my refractive error were the 20s to 30s, maybe early 40-year-olds. And now I'm seeing 50-year-olds and 55-year-olds and even 57 and 60-year-olds coming in wanting their refractive error corrected. They're not quite to the point where they have cataracts, but they're dealing with bifocals and trifocals, and they're wanting their refractive error corrected. And so it's becoming more and more of a lens-based surgery. So I'm seeing the biggest increase in the refractive lens exchange. And
Yeah,
so I get the question oftentimes from ODs, how much myopia and hyperopia can you treat with corneal laser surgery? And they'll ask me oftentimes, well, their Ks are this, how far can you go? Where are you comfortable with a K reading being after? So you've got someone who has a 41K and they're a 6 diopter myope. Are you okay with reducing them down close to, well, 80%? You'd probably be about 36, 37. Are you okay with taking a cornea that flat? Or how steep can you go with the cornea? Are you okay with making, I don't like making corneas worse than 49, and I don't like making them less than 36. And so that's kind of my ballpark range. But where are you guys at there?
Yeah, I'm really similar. And just like you, I'd say my default is LASIK, but I have a smaller window now where I'll switch them to ICL. If boy, 36 is okay, but I prefer they didn't go below 38. You can go below 300, but I'm really, really hesitant too on thickness. And so I have more of a hair trigger to switch them to ICL from LASIK. We've talked about, we're doing more LASIK and we're doing a lot more RLE. Brent, what are some of the new technologies in LASIK specifically that we've seen over the last few years in the development of LASIK? And then Doug, maybe you can go through, we're doing a lot more RLEs. What's the technology in that category that's changed and that we're doing more of?
So I would say with LASIK, there's a couple of different widely used laser platforms, and each platform kind of has its own brand of customized treatments. And when we look at LASIK, I would say the majority of my LASIK is something called wavefront optimized LASIK. And that's where we take a refraction and we take a patient's K measurements, and it's almost like an algorithm. So it's customized a little bit in a sense. It's not just plug in their refraction and ride. It takes into consideration their Ks. You can get an iris registry on that to make sure your axis of astigmatism treatment is appropriate, all of that good stuff. There is the opportunity to customize when needed. And so if a cornea is maybe a little irregular, you can go in and do a topo-guided treatment. And that's where we get topography or an image of that cornea. and we program that into the laser. And I think where this has really come a long ways in the last 5 years is an advanced planning algorithm called Forcities. And so that just takes it to the next level. And Forcities, what Topo Guided does is it says, hey, here's your irregular cornea, and it treats three things. It treats the irregularity, it treats the astigmatism, and it treats the nearsightedness. And what Forcities is a program where we run that through. And what that does is it says, hey, we've treated this irregularity. How is that going to affect the glasses prescription? And then it recommends changing the astigmatism and then the spherical treatments based off of each of those. And so it really makes our customized treatments a lot more accurate. A study we did here at Vance Thompson Vision showed that they're pretty similar when you bring all comers in. So again, we can't turn our brains off and just say, yep, refractive surgery, let's go. We're really kind of looking at the patient, looking at the cornea, saying what's best for that patient. And so, we get down to LASIK, and then I'm looking at everything and I'm saying, what's the best treatment for this LASIK patient? Is it a wavefront optimized, or is it a customized treatment like a topo guided treatment? So,
Yeah, and it's nice to have those options, so here we have all the different options on whether that's wavefront guided, wavefront optimized, topography guided, and you can match the right technology to the right patient, which is so much of what we do. Is we've got all this technology out there that's really amazing, and the expertise is figuring out what is the right technology for the right patient at the right time. And I think that's so true today with lenses and RLE. Doug, how do you talk to patients about that? And what have we seen in the last few years with the explosion of lenses that have really opened up RLE for a lot of patients?
Well, I think the optics that we've seen improve so much over the lenses. The original multifocal lenses that we had that came out had so many side effects to them that it just got prohibitive to put them in. You could get people to see pretty decent distance and near, but some of the earlier multifocal lenses created so many glare and halo and starburst at nighttime, and they got image quality issues and all of that going on that it became really hard to recommend it. And so the change in the optics, the optimizing these optics and these implants over the last 10 to 12 years has really made a significant difference in how well people do. And we still see it today. I mean, we have 2 or 3 different clinical trials going on right now with new optics in advanced implants, whether that be extended depth of focus or diffractive multifocals. And so, and now you've got all these options. So where before, 28 years ago when I had my LASIK done, there were 2 lasers available, and there was a microkeratome flap, and you had a couple of those to choose from. But it wasn't really matching much for technology. You just had a small amount of technology to treat a large number of refractive errors. And now with corneal surgery and with lens-based surgery, we've got all of these different technologies that it really has become an exercise of, you may be a candidate for 3 or 4 different really good technologies. Okay, which one matches best with your eye, and which one matches best with your expectations and how you use your eyes and what your goals are and how you correct your vision. So it's the optics of these lenses, I think, number one, has made it so that people aren't waiting until they develop a cataract and are really struggling. They're willing to do a lens-based surgery now so that they don't have to wait 8 years or 6 years or 12 years to get a cataract before they can take advantage of some of these really good optics. The other part of that is the part that you guys do. I mean, this is a 5 to 9 minute topical anesthesia surgery only. And I mean, the advances in the surgical realm of what you guys are doing has made it also so that risks have been lowered significantly. This is fairly easy to go through. It's a quick recovery. People are able to go back to a pretty normal routine in their life within a day or two after this lens-based surgery. And so when you put all of that together, people are now in their late 40s and early 50s saying, why do I want to wait 10 years to get a cataract to take advantage of this cool technology when I can correct it and have it now, and that's going to last me from now on, rather than do a corneal based surgery? So I think that's where this lens-based surgery is making so many inroads, especially with the refractive lens exchanges.
And so much of this is choosing the right patient and figuring out who is the wrong candidate as much as who's the right candidate. And that comes down to a lot of what we do with our diagnosis and our diagnostic tools at the beginning. You know, we've got topography, tomography, epithelial mapping, biometry. Brent, kind of talk about, you know, the process that we use to get all those tests and how we're using those tests as we're trying to make the most accurate measurements pre-op and give people the best outcomes post-operatively.
Yeah, a lot of this is, you know, good information in leads to a good result. And so garbage in, garbage out. And so it's important, those measurements that we're getting, because they go into the algorithms and they help us pick a lens for a refractive lens-based surgery. And so important. I think, you know, the one that really stands out to me is epithelial mapping. It helps in so much of my decision making, to a point where it's kind of become something regular. I get it in every refractive patient. I get it in, you know, pretty much all of my, you know, refractive cataract or RLE patients as well. And so it's just nice to see how regular is that epithelium. It's helped me decide between doing LASIK or doing the rare PRK or on a patient where maybe we would have considered doing a lens-based surgery or a cornea-based surgery. It's a little bit at risk. There's some epithelial thinning, which maybe puts that patient at risk for ectasia, and it pushes me towards something like an ICL. And so it's having that data. It just helps us make better decisions. And ultimately, you know, I was saying earlier, you can't turn your brain off with this stuff. It's just not plug and play. It's nice to have all of that technology available. And then it's an art. And ultimately, you know, we look at all of that data and then you know, I usually recommend what I would recommend for myself. Boy, if I was sitting in this chair, this is what I would do for myself. Or if you were my mom, this is what I'd do. And that's where it's nice. The other thing is, it's not, you know, when I look at cornea-based refractive surgery and lens-based refractive surgery, it's so important that you are able to do both and do both extremely well. You don't want somebody that dabbles in one or the other, because so many times lens-based surgery might need a cornea fine-tune, or, you know, if you only do LASIK and aren't comfortable doing a refractive lens exchange, you might be doing LASIK on a 55-year-old because that's the hammer you got. And so it's important to have, you know, a doctor that's comfortable in the breadth of refractive surgery offerings and does have all of that technology. So that way the patients, you know, are getting a good result with that.
Yeah. Doug, you know, we've been doing LASIK now for, you know, over 30 years. It's been around a little bit longer than that even. You know, talk to us a little bit about, we know, what's the long-term stability? What are the long-term visual outcomes? What's the patient satisfaction with LASIK and corneal-based refractive surgery? And you know, me and you have both had it. You've seen a lot of patients over the years that have had it. Tell us a little bit on the data and what your experience has been.
LASIK has a great track record over the years, and not only for good longevity of the effect of the LASIK, because we know that these corneas, especially when you don't push LASIK beyond or towards its limits, LASIK can remain very, very stable over time. You know, we all see the RK patients that come in. They're getting fewer and fewer now as I get older, but we're further away from it. But for a long time, we were seeing a lot of RK patients that were changing a lot with time, you know, and that's the one thing that we haven't seen with LASIK, that LASIK has not done the same thing that RK has. People who have LASIK don't have a continued effect over time. And so it's nice and stable over time as long as the patient's correction isn't going to change. But now we're recognizing that change doesn't just come from someone who's in their 20s, 22, who's going to get normally more myopic as they move into their 20s closer to 30. But now we have people who are stable most of their life with their myopia, but as their lens changes in their 40s and 50s, they're having small changes in their refractive error. Their LASIK didn't really change. It's just that their lens changed. And so I think we're dealing more and more with lens changes than we are corneal changes, because LASIK has been so stable over time. But I think we've learned a lot over time also because of the amount of time we've done LASIK, where to push it and where not to push it. And this is where the diagnostic technology that Brent was talking about comes in, is because we can get so granular now with our diagnostic technology. We're really figuring out who shouldn't be having that done, or when are we pushing them too far. And now even to the point where we're talking to somebody who might have 10 years ago been a pretty good LASIK candidate, but I'm telling them that if you treat your 7 diopters of myopia now at 35 years old, that may have an implication of what you're going to do when you get a cataract 15 or 20 years down the road, and what lens choice you're going to have. And IOLs and will improve over time too. So we're probably going to eventually figure out how to handle the corneal changes that we do with LASIK and how to treat them with even better lenses in the future. But we're having that discussion now with people who are in their mid to late 30s. What implication does this have down the road when you're 58 and you're having a lens-based surgery because of an early cataract? Is that going to hamper your ability to have the most advanced technology and correct your vision?
You know, Doug, you said it so well, and I want to hop in and just applaud, you and Vance and Keith who've been doing it for so long, 30 plus years, like you said, because while we don't do comprehensive eye care, and typically I'm not seeing a patient every year of their life, we're not a pop-up LASIK shop that's, doing LASIK inappropriately because we know we're not going to be around in 5 or 10 years. Boy, I want to do a patient's LASIK now. And 15, 20, 30 years from now, I want to be their eye surgeon down the road too. And you guys have done it so well. And that's why, it's an honor to work alongside you guys, because you have such a reputation in the community for doing that. And so, it's important for us, and we think about that. We make those decisions. I tell a -8, boy, if it were my eye, I could get away with LASIK, but I would do an ICL if I were you, because in 10 to 20 years, you're going to need a lens. And I want to have all of the options on the table for you.
Exactly. Leaves you so much more options out there.
Yeah.
So.
Yeah,
And I usually tell them, I usually say, don't let convenience or even a little bit of extra money make the bad decision. If I were you, if I can't afford an ICL this year, I'm probably not doing anything. And you could probably go to 3 other LASIK shops that would do LASIK, but I wouldn't recommend doing it. I would just wear your contacts for another year, save up for that ICL, because, buddy, you're going to love it. Conversations like that.
Yeah, that longitudinal, refractive surgeon for life sort of idea. That this is a journey that we're on with the patient, and from 20 to 30, they have different needs than they have from 40 to 50. And we're thinking about, hey, how are we going to treat that patient when we get to 40s and 50s, knowing what we know now? And so much of that really comes down to managing patients' expectations. Doug, how do you manage a 20-year-old's expectations versus a 50-year-old's expectations on what they're going to see and what their goals are going to be?
Yeah, and the main difference between a 20 and a 50-year-old obviously is the lens changes that are coming about. But with the 20-year-old, my main focus with a 20-year-old is how stable have they been up to this point, and what's their stability going to be going forward? Because I need that 20-year-old to know that if they're a 3.5 diopter myope and they've only had small quarter diopter changes maybe with their OD over the last 2 or 3 years, I need them to understand that at 20 years old, by the time they're 24, they might be a 1/2 or 3/4 of a diopter more myopic than they are now. So if they do LASIK now, they may be needing some temporary glasses or some contact lenses until they've stabilized to do a fine tune down the road. And that's where you've got to go and really closely evaluate their cornea and where their eyes are at, so that you've got enough room to do that, and they understand that there is some risk at that fine tune down the road. Trying to maximize the chance that somebody only has to do one corneal surgery is what our goal should always be. And so if we have to do an enhancement or fine tune because somebody over or under responds, that's fine. It's just you want to try to enhance the percentage that they're going to get a good correction, and it's going to last them for a long period of time until their lens changes down the road. The 50-year-old, I don't remember the last time I had a 50-year-old who really opted to do LASIK. Come to think of it, because I'm having the conversation with them, you can do LASIK. It's just that you're going to get a year or two down the road, and your lens is going to change a little bit. That may or may not mean some distance effect in vision. It's certainly going to mean effect more for up close. And are you okay with that? And whether you're 20 or 30 or 40 or 50, I basically let them know that I want to make sure that they feel like they got a good value. If I feel like at a 20-year-old you're going to get a good value out of LASIK over a long period of time, then I'm going to be all for it. If I don't think you're going to get a good value out of LASIK as a 50-year-old, I'm not going to recommend that you have LASIK, because I think probably a lens exchange or another option is probably better for you. And so those are the main conversations. It's almost as if I'm having a value proposition discussion with these patients, depending on which decade they're in. Even though they all may be the same, they may qualify all as the same good candidate for LASIK.
Yeah, great. Brent, any closing thoughts on how do you make sure expectations are managed? So much of what we do are, we're trying to educate patients. We're not trying to sell them anything. We just want their them to feel like this is exactly what I was told I was going to get, and I'm not surprised by it. What do you think the key take home point for that is?
I empower folks to go home and do their homework, say, hey, if I were you, I'd do this. It sounds like this is the right choice. But go read about it. Go talk to a friend. So many people have had LASIK. Talk to them about it. But it's one of those things where we're an eye organization that's been around for a long time and plans to be around for a long time. And so going and making a bunch of patients unhappy really doesn't work for us, right? We're Vance Thompson Vision that's been around for 30 years and wants to be around for even longer than that down the road. And so we want to make sure that patients are educated and they know exactly what they're going to get. And so you can generally have that conversation with the patient, size them up, and some people need a little bit extra time to talk about it. And I have no issue. Just prior to this podcast, I just got off the phone with a refractive consult I saw back in November, and he just wanted to think about it. And I called him up and we talked about it. And he's coming in on Monday for LASIK. And so it's hey, go home, think about this. This is your eye. This is a really big decision. And I'm here for you when you need us, buddy. So.
Well, thanks guys for your time today. It was really fun. Look forward to doing this again in the future.
All right.
Thanks for hosting, Dan. Thanks, Doug.
See you guys.
Thank you for tuning in to Advanced Patient Care, the exclusive podcast by Vance Thompson Vision. Want to learn more? Schedule a personalized mini fellowship at one of our clinics where you can gain hands-on experience and real-world applications tailored to your practice. For more resources and information, visit vancethompsonvision.com/OD. Let's continue advancing patient care together, one episode, one innovation, and one patient at a time.